we're going to talk about 4 very interesting cases which presented not typically. And you know that hypertension presentation in children is often vague. So they presented in different manner. And then at the end, we found very interesting diagnosis. So this is the whole spectrum. So when we talk about hypertension or blood pressure regulation, there are 2 major factors which are there. One, of course, is how much is the cardiac output and how much is the peripheral vascular resistance. So these are the 2 major determinants, and many of the endocrine factors will play a role in that perspective. So we know that calcium is a major stimulant as far as the vascular constriction is concerned, and that is why calcium channel blockers are used for management of hypertension. We know that the fluid is largely regulated by multiple endocrine systems, and important factors, of course, are the sodium and the growth hormone. Both play an important role in the fluid regulation per se. Then cardiac contractility and the heart rate is determined largely via the thyroid function. So there are multiple endocrine organs beyond the adrenals which are also involved in the whole perspective. Coming on to the most important part, of course, is the renin, angiotensin, aldosterone system, in which renin basically converts the angiotensin, and then we have the ACE converting into angiotensin 2, which triggers the adrenal production of aldosterone, which is a primary regulator of sodium absorption in the body. Now, adrenals also produce cortisol, which are the trigger as far as catecholamine production. So overall blood pressure regulation involves a number of hormones, and disorders there could cause what we can say, quote unquote, endocrine hypertension. So we all are aware about thyrotoxicosis, increased renin state, which can cause that, hyperaldosteronism, which can be primary or secondary, Cushing syndrome or cortisol excess, excessive catecholamine production like pheochromocytoma, of course, will cause that. And we also know that hypercalcemia and hyperparathyroidism and growth hormone excess can also cause this. So a large number of endocrine disorders are important factors as far as hypertension is concerned. Most of them, be it thyrotoxicosis, be it hypercalcemia, be it growth hormone excess, the symptoms will be clear. The symptoms may actually be quite vague for a aldosterone producing tumor, and this is what we're going to focus more in terms of what we can say, quote unquote, increased aldosterone effect. So either the aldosterone is more, or there is another molecule which is behaving like aldosterone acting on the receptor, or the receptor itself is hyperactive. So that becomes important. So when we talk about increased aldosterone effect, the situation can start right from the production of renin. So you can have scenarios in which there is increased renin production. The classical example we all know is a renal artery stenosis, in which the kidneys feel that there is no blood flow and they are going to push a lot of renin to increase the perfusion, causing hypertension. There could be issues at the level of adrenals, which are producing more aldosterone. And this production can be because of an isolated adrenal adenoma, adrenal hyperplasia, or what we call as a glucocorticoid remediable aldosteronism, which is basically a splicing defect in which the regulation of aldosterone secretion happens via ACTH, and that is going to control that. We can, of course, have a problem in the 11 beta HSD2, which basically shields the mineralocorticoid responsive tissue from the impact of cortisol. So if there is a 11 beta HSD deficiency, like apparent mineralocorticoid excess, you can have a scenario. And similarly, of course, in Cushing's, you have got so much level of cortisol, particularly if it's an ectopic form, which is there. In those scenarios, you may have hypertension, hypokalemic alkalosis, which will happen. So that is actually a apparent mineralocorticoid excess scenario. You can also have increased activation of the epithelial sodium chloride channel, and this also is going to trigger increased activity. The classical example is Liddle syndrome, in which the epithelial sodium chloride channel is more working. You are absorbing more sodium, causing hypertension in that regards. As I said, you can also have aldosterone-like molecule, which have got mineralocorticoid activity. The classical example is DOC, which may be produced in the setting of CAH variants like 11-hydroxylase and 17-hydroxylase. 11-hydroxylase will classically present with XX-DSD and precocious puberty in boys. 17-hydroxylase will present more with XY-DSD and delayed puberty in girls. So these are the overall gamut of scenarios which may be causing an increased aldosterone effect. The problems could be because of a true increase in aldosterone, which would basically be either an adenoma or a hyperplasia. There could be a familial cause like glucocorticoid remediable aldosteronism, which I said is because of the regulation of aldosterone production via ACTH. So it's an unusual production regulation via ACTH. Then you can have a DOC excess because of a tumor or 11 or 17 hydroxylase deficiency. And then finally, you may have no increase in aldosterone, but there is an apparent excess because there is decreased conversion of cortisol to cortisone, resulting in apparent mineralocorticoid excess or a Liddle syndrome. So we'll be discussing about probably 5 to 6 cases if we get time, but there are 4 key cases which will focus about pretty much starting right from adenoma to 17 hydroxylase deficiency to 11 beta HSD deficiency and a level higher also about renal artery stenosis. So we'll talk about a lot of these constellations approaches from that perspective. All of you can go and have a look at our website, learning.gosociety.in, which has got a lot of free resources as well as courses and fellowship programs and diploma in endocrinology, which are available. We do run around 3 programs a month with regards to the journal club, the postgraduate lecture series, and the grand rounds covering these aspects. There are publications which are available both online as well as hard copies and mobile application which can be used for access and point of care. So what we'll do today is to focus about 4 cases after we have the basic understanding of approach so that it becomes easier. So we'll talk about a case of high renin, then adrenal mass, recurrent stroke, and hypertension with nephrocalcinosis. These are 4 very interesting cases. If we get time, we'll talk a bit about 11 hydroxylase and 17 also as case vignettes in that regards. So now in this background of the overall approach for these causes, the questions are, is it really an increased aldosterone effect? If it is an increased aldosterone effect, is it because of an aldosterone excess or an apparent excess? And finally, what is the cause? So as we have discussed that hypertension is particularly common in older individuals. But if you have a young individual and there is a hypertension, we are always worried about that. So if there is an onset of hypertension before 20 years of age, and in children, we know that first you have to exclude all the renal parenchymal and the renovascular causes. Once you have done that, you can think of pheochromocytoma, you can think of coarctation of aorta, then you're talking about an endocrine cause or a low renin cause of hypertension. However, it has now been identified that around 5% of what we call quote unquote essential hypertension in adults is actually because of aldosterone excess. So if you have onset after 20 years also, but requiring 3 or more medications, you have to worry about that this could be a secondary hypertension and do a basic screening for the aldosterone excess in that regards. Now, within a group of individuals who have hypertension, if they have frequent muscle cramps, which basically would mean hypokalemia or hypomagnesemia, if they have features of polyuria and failure to thrive, strong family history, particularly for the autosomal dominant variant, which is the glucocorticoid remediable aldosteronism, and as I said, polyuria and hypokalemic alkalosis, you are thinking more in terms of endocrine hypertension. Now, one concept often people have that everybody who has got a hypokalemia, we are going to think about aldosterone excess. So if the potassium is normal, the chance of aldosterone excess is less. This is untrue. A large number of patients who actually have endocrine hypertension may have normal potassium. And this is an important message to consider, that you have to consider even if the potassium is normal. If the potassium is low, you definitely have to worry, but normal potassium does not exclude the possibility of this group of disorders in that perspective, and that becomes important from that regards. Now, how do we, once we have decided that this is possibly a renin-angiotensin effect, how do you assess the scenarios from there? So essentially, we have already discussed that we have got angiotensinogen, which is converted via renin to angiotensin 1, which is converted via the angiotensin converting enzyme to angiotensin 2, which actually is a very, very important agent as far as fluid regulation is concerned. Angiotensin 2 causes vasoconstriction, increasing blood pressure. It increases aldosterone secretion. It increases thirst. So it has got multiple mechanisms by which it is acting to increase the fluid status overall from that perspective. And this aldosterone will then cause action on the mineralocorticoid receptor to assess. So if we talk about the renin-angiotensin-aldosterone system, the assessment can be done at the level of actual measurement of renin, which is a direct renin assessment, or a plasma renin activity. Now, direct renin is basically an immunoassay. Plasma renin activity is actually a bioassay. So we need to be careful when we differentiate. We'll talk a bit about how they are different and which is preferable in that regards. We, of course, have to measure aldosterone in combination with renin, like we say FT4 TSH, ACTH cortisol, insulin glucose, calcium PTH. Same is that aldo has to be combined with renin to get any meaningful result in that perspective. So the screening investigation essentially for anybody whom you're thinking of endocrine hypertension is an aldosterone along with renin level. Now, what you need to be cautious about that this should be done ideally in the morning around 8 a.m., 2 hours after the patient has waken up. Very importantly, 5 to 15 minutes of sitting posture is important. And because if you're doing particularly a plasma renin activity, which is a bioassay, you should use a pre-chilled tube. Otherwise, you will have a falsely declined level as far as the renin is concerned. Now, we all know that there are two types of assays available. One is the renin and other is the direct renin content. So plasma renin activity is basically a bioassay, and direct renin is essentially a form of an immunoassay in which you are measuring the renin content in that perspective. Now, very importantly, the renin activity will depend upon angiotensinogen, how much angiotensinogen is available there, and it is not affected via estrogen. So the major differences is if you talk about cyclical variation, you will have much more variation which happens in direct renin content as against a plasma renin activity. So during ovulation, if you want to look at PRA will be a much better strategy rather than a direct renin content from that perspective. Moreover, the assays are more robust for plasma renin activity. So most of us will go for plasma renin rather than a direct content. But if you are going with either of them, remember the ratios will be different. The aldosterone to renin ratio will be different and your interpretation will vary also from that perspective. So this is something important to identify what your lab is doing and how do you want to assay from that perspective. Very importantly, if somebody is restricting salt, or in a standing state, you will have an elevation of renin. Levels are typically highest in morning, and renal failure, of course, is a scenario where your renin will be less because it is being produced by the kidneys also in that perspective. Now, another very important problem which happens in these scenarios is that many of these patients are already on many medications. So what is the impact of those medications when you are assessing the aldosterone-renin ratio? Because otherwise, you will get a false positive or a false negative result in that perspective. So if you have intake of spironolactone, essentially we're talking about calcium channel blockers, ACE inhibitors, ARB and spironolactone, all of them will suppress in a way aldosterone activity. So that will falsely give renin levels which will be high. So you will miss primary hyperaldosteronism. On the other hand, if your renin is still low, in somebody who is on ACE inhibitor, on ARB or spironolactone, you are 100% sure that this is a low renin or an endocrine pattern of hypertension. If somebody is on sympathetolytic agents, if you are beta blockers, central agents like clonidine, methyl dopa, these are all going to inhibit the central sympathetic trigger. So therefore, you will have a low level of renin, and because renin goes low, your aldosterone to renin ratio will go up. And you will falsely label somebody, okay, he does not have primary hyperaldosteronism, but you will say this is primary hyperaldosteronism. So these drugs should be avoided in that perspective. Direct renin inhibitor is not very commonly used now. That also causes a confusing scenario in which your PRA is less because you are antagonizing renin. So your bioactivity is less, but your immunoactivity is normal, because your renin content will be normal, but this is something which is not really commonly used in that perspective. So what do? We shift them to drugs which do not affect these ratios, which could pretty much be an alpha blocker like prazosin or a calcium channel blocker like verapamil, which can be there. So prazosin is a good drug to start off in that perspective. Now, very importantly, if somebody is on spironolactone, somebody is on ACE inhibitor, somebody who is on ARB, you expect them to develop hyperkalemia. If they are hypokalemic, then that is something that this is actually overriding the effect. This is 100% sure that this is an endocrine form of hypertension or renin excess, which is there in that perspective. Now, when you're assessing the RAS system, you need to remember that like FT4 and TSH, like calcium and PTH, like glucose and insulin, there is a log linear relationship between aldosterone and renin activity. If your aldosterone level goes up, renin should be zero. So you have to basically correlate between aldosterone and renin, and they have to be done parallelly in that perspective. So if aldosterone is high, PRA level should ideally be low in that perspective. This is primary hyperaldosteronism. If, however, your PRA is high, it means renin is driving the whole picture. And this would mean something like a renal artery stenosis sort of a scenario. Now, how do you interpret this? So what I'm doing now is to use PRA, plasma renin activity, which is more commonly used. And I would prefer that because it's a better bioassay. And the ratio between aldosterone and plasma renin activity, which is ARR, or plasma aldosterone to plasma renin ratio. If aldo is more than 10 and renin is undetectable. So theoretically, whenever we say your FT4 is high, TSH should be 0. If your aldo is high, your renin should be 0. This is classically primary hyperaldosteronism. You don't need to worry about this in a great extent. However, if the renin is high and the aldosterone to renin ratio is less than 10, this suggests a hyperrenemic state. And we'll talk about both scenarios. If both of them are low, this means that there is some other form of mineralocorticoid which is acting, which could be a DOC, or there is an apparent mineralocorticoid excess, or Liddle syndrome. These are the possibilities which will be there from that regards. So now if we compare the common etiology in the form of renal artery stenosis, adrenal adenoma, hyperplasia, these are pretty similar. GRA, these three will be similar. CAH variants, AME and Liddle, renin level will be low in everybody except a renal artery stenosis. So in this scenario, your renin is high because that is driving the overall picture. If we talk now about the aldosterone level, the levels will be high in everybody except for apparent mineralocorticoid excess, Liddle syndrome, and CAH variant. So if you have low renin, low aldo, you're talking about either DOC or you're talking about 11 beta HSD or Liddle syndrome. And finally, if you have renal artery stenosis, CT angio will give you a clue. For adrenal adenoma hyperplasia, CT becomes important. For CAH variants, as we'll discuss, there would be the option of doing the specific metabolites. For AME and Liddle, you can use the impact of spironolactone. Now, if somebody is responding to spironolactone, it suggests an apparent mineralocorticoid excess. If they are not responding, this suggests a Liddle syndrome. And now, of course, genetic diagnosis can also give you the precise diagnosis in the form of a clinical exome sequencing, which you can do. So the approach to an individual who presents to us with suspected endocrine hypertension is to look at the renin level. If the renin level is high, possibility is renal artery stenosis, go for a CT angio. If the renin level is low, go for DOC level. If DOC is high, this is 11 or 17 hydroxylase deficiency, go for a tumor, go for CT and genetics. If you have got low DOC and your aldosterone is high, this is primary hyperaldosteronism. So low renin, high aldo, then you go for CT, and then young patient, family history of recurrent strokes, think of a GRA. So response to steroid will be significant. If you have got a low renin, low DOC, low aldosterone, this is either two differentials. You're thinking of either an apparent mineralocorticoid excess or a Liddle syndrome. Look for spironolactone response. If it's there, it's most likely a 11 beta HSD2 defect, which is apparent mineralocorticoid excess. In this case, you can do a genetic study. And if you have got no response, this is most likely a Liddle syndrome and you have to go for a genetic study. So basically, go for a combination of renin and aldosterone. These two will give you a clue. DOC will also be helpful, and then spironolactone response. High renin, renal artery stenosis, low renin, high DOC. You got specific diagnosis, but you will get clues. If there is a XX DSD, think 11. If it's a XY DSD, think of a 17. If, however, these are not there and your LDO is high, look for an adrenal tumor. If your LDO is low, look for spironolactone response and you will get the diagnosis.
A 7-year-old boy born out of third-degree consanguinity, he presented with a complaint of high blood pressure since 1 year of age and 2 episodes of stroke in the last 2 years. At the age of 1 year, when he was operated for the inguinal hernia, he was diagnosed with hypertension. It was pretty scary for the parents that his 1-year-old child has hypertension, has high blood pressure. So they went to multiple clinicians, and but they were not satisfied with the treatment because they were not really ready to believe that the child has hypertension, as there was no family history of early onset hypertension, stroke, coronary artery disease, any feature suggestive of MEN2. And multiple investigations were done just to rule out the common causes of hypertension. Creatinine, thyroid profile, electrolytes, all were normal. Even 2D echo was done, which was normal. CT angio was done just to rule out the renal artery stenosis, which was also normal.
And there was no hypokalemia.
There was no hypokalemia at that time.
How is this case different from Vali's case?
Sir, that child has presented late. He presented this very early.
So whenever we talk about severe, syndromic, segregated, and soon. So this you have to start thinking of something is not wrong. This child had hypertension 1 year detected. You know, it must have been there for a long time. So this is too soon. You have to think of a genetic cause.
So it was not just a one. His blood pressure was maintained on 3 or 4 antihypertensive drugs. Then in 2018, he had severe headache, which was followed by loss of consciousness, and he was hospitalized. During hospitalization, he complained of lower limb weakness and polyuria. So, and again, a panel of investigations were done. Serum sodium, which was normal. Serum potassium, again, 3.1, lower side.
Was he on thiazide?
Sir, I think during the hospital, no. Before hospitalization, he was not on thiazide. But when he came to hospital, he complained of lower limb weakness. Might be some diuretics were given, and that has led to
very important message again.
That has led to the
weakness means basically a
myopathy.
Cramps.
Yeah.
And polyuria, again indicative of hypokalemia. So that you have to watch.
That has led to the
diuretic induced
hyper. Even the 17 OHP was done just to rule out the CH variants. Metanephrines and non-metanephrines were done just to rule out the
CH variants. Which variants are you thinking?
Sir, in this boy, there is no history of precocious puberty, and there is no history of any in this.
So, if I'm talking about now clinical perspective, before we go ahead investigation, you have got a young boy who has got severe hypertension, and you're thinking of CH variants. So, there are 2 variants which are hypertensive. If it was 17 hydroxylase, how will the child present?
So he will present with ambiguous genitalia, DSD.
No development,
yeah.
So that is unlikely. If it was 11 hydroxylase,
then he will put precocious puberty.
So both of them are unlikely.
Yeah.
But you cannot, of course, exclude it. But that is very unlikely in this scenario. So if you want to do a test to rule it out, which one will be the better one?
So for doing.
So 17 OHP
do you see?
You have to better to do a
DOC we can
or a 17 DOC. If at all you're worried, but my likelihood of CH in a male child with no evidence of precocious puberty or DSD hypertension is very, very low. So I'm not really thinking about. So you have to look into the clinical scenario as well.
Right. But these were the investigations before he came to us. So the the valuable information that we get from these investigations was the low potassium, hypokalemia. So he was on hydrocortisone, amiloride, furosemide, atorva, and aspirin was started. He was taking it, but even on taking so many medications, he had second episode of stroke. So, but on and after second stroke, he came to us. Then we inquired the family. We get some more information, And the family said that he had no this history of spells of headache, palpitations or sweating, no history of precocious puberty, increased pigmentation, any weight gain, proximal muscle weakness or purple striae, any history of Ayurveda medication or a licorice intake, that is the mulethi, and any history of weight loss, heat intolerance, goiter, and abdominal pain and recurrent renal stones. So, on the examination, what we found is he was growing pretty well. He was prepubertal, and on the vitals, pulse rate was 90 per minute. All the peripheral pulses were palpable. There was no radial and no radiofemoral delay. Respiratory rate was normal, and the systolic blood pressure was 126 mmHg. That was 95th percentile plus 12 mmHg. That is a stage 2, I guess, stage 2 hypertension. And diastolic blood pressure was 62 mmHg. That is 58 to 90th percentile. There was no significant difference between the upper and the lower lip blood pressure. On the general examination, there was no pallor and pedal edema, no dysmorphic facies, no Cushingoid facies, acne, hirsutism, or striae. There was no neurocutaneous markers. There was no organomegaly or ambiguous genitalia. So we have a boy with early onset refractory hypertension taking 3 or 4 antihypertensive medicines. He has a history of recurrent stroke. He has hypokalemia, which accentuated on taking diuretics, normal renal function tests, normal 2D echo, and no evidence of renal artery stenosis. So by looking on all these parameters, we get a clue, definitely this is a case of increased aldosterone axis. So it could be a increased aldosterone or apparent aldosterone.
Now, if you go clinically, if you talk about increased aldosterone levels, the possibility will be adrenal adenoma, which is too early for this age.
GRA.
So the second is hyperplasia, which also typically happens after 20 years. GRA. So you're talking about glucocorticoid remediable aldosteronism versus a Lidl or an apparent mineralocorticoid.
Yes,
so these are the 3 differentials. CH, as I said, is unlikely. Do you think this could be GRA? Is it fitting into the classical presentation of GRA?
So first of all, there is no family history of any stroke or hypertension. And secondly, he was given hydrocort. If it was GRA, then it would be.
What is the usual age of presentation?
It was
what is the severity?
So GRA, it was at around 10 years or
it
like
is the second decade. So glucocorticoid remediable aldosteronism, your aldosterone levels will only go up when your ACTH goes up. So there will be an episodic hypertension. It will be not very severe. Not to this extent to cause stroke in the first 2, 3, 4 years of life. That is 15, 16 years of age that is there. It's an autosomal dominant condition. So it is more likely to have a family history, but you can say, okay, this is the first time you are picking up in somebody has got a mutation. So GRA becomes less likely because it is much younger, much more severe.
Yes.
So 2 differentials. If I talk about endocrine hypertension, we are pretty much CH is most likely out, GRA is most likely out. I would say this is either apparent mineralocorticoid excess versus a little stroke.
Yes.
Now within the 2, do you think which is more likely?
Sir, within the 2, more likely.
Which is more severe?
Which is more severe? AME, because
Lidl's also is very, very severe. So Lidl, you will have a much earlier presentation, 1 month, 2 months, polyuria, hypokalemia. The severity of hypokalemia here is less.
Yes.
So what is happening in this scenario? When your cortisol goes up, you have hypertension. You get the point? Because cortisol has to be inactivated. That inactivation is not working. So the severity of AME is in between Lidl syndrome and the GRA. So if you talk about 3 disorders, glucocorticoid remediable aldosteronism, apparent mineralocorticoid excess, and Lidl syndrome, Lidl will be the most severe, earlier onset. Second will be AME. Third will be GRA. So this child is too young for the glucocorticoid remediable aldosteronism and too old to present for Lidl. It is unlikely that Lidl will survive without hypokalemic paralysis or something. So this is an absolutely right scenario for AME as far as clinical diagnosis.
Yes.
Of course, investigations will tell us it.
So we send plasma aldosterone and plasma renin activity, and both were low. So this is rightly fitting into the diagnosis, both low plasma renin activity and low aldosterones. And this is, and let's see the approach as described by the sir. If we have low aldo and low renin, then we'll see the spironolactone response. And if there is no response, then it will be little. And if there is a response on the spironolactone drug, then there will be AME. But we have to do the genetic test for the confirmation. Now, the genetic study was done, and we sent the clinical exome sequences, and we found 11 beta HSD2 deficiency. And after the results, we stop the steroids and we start the aldactone. And as we see the treatment course, as we start the aldactone, as you can see in the slide, right from the December 2019, when the blood pressure was 120/58, we started the aldactone 25 mg per day along with the amiloride and the furosemide. But now in the November 2020, we are able to taper the aldactone to 18.75 milligram per day, and he is able to maintain the blood pressure with 116/56, and there is no hyperkalemia.
So this child was actually started on amiloride and hydrochloride, based upon probably by the treating physician were not clear about the diagnosis. So they were covering both CAH as well as Liddle syndrome.
Yes.
But funnily enough, he didn't have both of them. So that's a bit unusual.
They were given Emifru with contains fluoro.
If they had given aldactone, so ideally, if you go by clinical algorithm, you could have given spironolactone first and then look for the response.
Yes.
So on a single drug of spironolactone, he is doing wonderfully. So this is like a precision therapy. You've got the diagnosis and you're treating. Problem is increased mineralocorticoid activity or suppressing mineralocorticoid. This is what precision medicine basically is. From that regard.
So the final diagnosis is the apparent mineralocorticoid excess, and what the AME is, it could be congenital or the acquired. It is definitely 11 beta HSD2 deficiency, or in the acquired, it is caused by the intake of the licorice drug, or it could be due to ectopic ACTH production where there is a high level of the cortisol. And in this, the excess cortisol is not inactivated to cortisol. And in the clinical features, you will get growth failure, refractory hypertension, hypokalemic alkalosis, and the hypokalemia is precipitated by loop diuretics. Okay.
So I think this was a good presentation and gives us two big messages. First of all, if somebody has hypertension at 1 year of age, we have to basically be very cautious. There has to be something pathological. If it was picked up at that time, we would not have had 2 strokes that this child is. He is neurologically reasonably stable, but this was a risk which was taken. Second is, look at the entire picture. If you look at it, he cannot be CAH. He doesn't have any DSD. He doesn't have any precocious puberty. If he has severe hypertension, he would have developed precocious puberty. So hydrocortisone will probably have no role in that perspective. And second, first spironolactone trial will be better. You can all go and have a look at our website and explore our courses and the mobile application.